Ultrasound Academy. It's an institution for dedicated ultrasound training located in Pimpri Chinchwad area in Pune. Hands-on training is given at KR Diagnostic Center, Bhakti Sonography Clinic and Shri Mauli Diagnostic Services LLP in PCMC area. Training is given by highly professional radiologists with more than 10 to 15 years of experience in the field of ultrasound. Training covers all aspects of ultrasound such as emergency, pediatric, gynecology, small part, OBS ultrasound, fetal medicine as well as invasive procedures under direct supervision of professionals. Personal level attention from faculties. Sufficient number of good quality ultrasound machines for training. Detailed teaching program with lecture series upon basic anatomy, scanning techniques, interesting cases, etc. Lectures from invited faculties, separate conference hall with AV facilities, complimentary FMM certification, separate WhatsApp group for academic students for academic discussion, and access to huge collection of well-documented ultrasound cases from archives of faculties.
Multiple umbilical portal venous system anomalies are known in the literature but are relatively rare in occurrence. These anomalies are usually diagnosed in the second trimester during anomaly scans. We are presenting few umbilical portal venous system anomalies encountered at our clinical setup. Just to revise anatomy in brief, this to the left side, we can see a right ventral mid-sagittal view. Here, we can see umbilical vein takes a curvilinear intra-abdominal course, enters the liver, and joins the left portal vein, which course abruptly to right away from the stomach, creating L-shaped segment portal sinus. Portal sinus gives rise to ductus venosus, which, along with the hepatic veins, joins the IVC at the subdiaphragmatic vestibule. The main portal vein joins the portal sinus, giving rise to right portal vein and its branches. This critical anastomosis forms alphabetical shape of X, H, or T. Documentation of this X of similar color, either red or blue, is essential to rule out intrahepatic portal venous system agenesis. Junction of the main portal vein to the portal sinus is situated inferior and to right with respect to ductus venosus origin. So, these are the typical normal waveforms of fetal veins. So, how to suspect these anomalies? First, when we see absence of the ductus venosus in NT scan, we see intrauterine growth restriction in second trimester. When we see abnormal vasculature like dilated IVC, prominent arms of the X, or we see triphasic flow patterns in systemic veins. So how to approach these cases? There are 3 steps. First 2 steps we all do routinely at NT and anomaly scan. That is documented anatomy from right to left, gallbladder, umbilical vein, and stomach, and documenting the portal sinus coursing away from the stomach. Second, the ductus venosus. We all do at the NT scan. We should look the location and the connection to the subdiaphragmatic vestibule and documenting the waveform. The only important additional thing we have to do is to document the X, which is the anastomosis of the main portal vein to the portal sinus, and the documentation of the color either red or the blue. There are multiple classification systems, but Achiron proposed most comprehensive classification based on the anatomical origin of the shunts. Type 2, ductus venosus systemic shunt. Type 3, portosystemic shunt, which is further divided into type 3A, intrahepatic. To the cases. In this sagittal section, we can see umbilical vein takes a curvilinear course and is seen blindly ending in the portal sinus. But we cannot demonstrate any intra or extrahepatic shunt. So this was a case of a ductus venosus agenesis. Total 5 cases were diagnosed. Out of these 3 were isolated. In one case, severe IUGR was seen in third trimester and was delivered by the LSCS. 2 other DV agenesis cases were associated with other cardiac anomalies and congenital anomalies, so these 2 were terminated. In one case, we offered amniocentesis. It was normal. Next is a in this sagittal section, we can see umbilical vein is coursing towards the heart. Instead of taking a curvilinear intra-abdominal course, we can see umbilical vein coursing towards the right atrium. There is absence of the ductus venosus and intrahepatic portal venous system. To the right side, we can see the diagrammatic representation of the same. This is another companion case. At the 12 weeks, we couldn't see ductus venosus, and you can appreciate well there is a fetal hydrops. IVC was dilated, and if we see at the bladder and the 3-vessel umbilical cord view, we see 2 red and 1 blue vessel. These 2 red are the umbilical artery because blood going from fetus to the placenta. So these are the red, and the blue one is the umbilical vein. The blood is coming from placenta towards the fetus. The IVC was dilated. You can see here. And there was an absence of the ductus venosus. So this was an umbilical systemic shunt. Total 3 cases were diagnosed. 2 cases were associated with the hemivertebrae and 1 had fetal hydrops. So all were terminated. This is the type where the cardiac failure, cardiomegaly, fetal demise is high. Next, in this type, in this sagittal view, we can see umbilical vein is taking deep curvilinear course towards the mid portion of the IVC. A DV-like structure with aliasing was noted far away from the right atrium. Normally, umbilical vein should take a curvilinear course towards the vestibule of the IVC. So this was a case of a ductus venosus to systemic shunt type 2. There was a small or abnormal DV seen. Total 3 cases were diagnosed. All were DV shunting into IVC. 2 were isolated finding and the pregnancy was continued. Other was associated with the tricuspid and pulmonary valve pathology and was terminated. This is a diagrammatic representation for the same. Next, in this case, we saw a communicating vessel between the portal vein and the hepatic vein. You can see here. So we thoroughly observe it on an axial section. You can see here, these 3 are the hepatic veins going into vestibule of the IVC. This is the portal umbilical vein going in. Communication was seen between the left portal vein and the left hepatic vein. You can appreciate here. So this type was a portosystemic shunt, which was a type 3A intrahepatic. Another companion case. Here, this is a stomach, left side. This is umbilical vein. This is a portal sinus going away from the stomach, giving branch right portal vein, and a communicating vessel was seen between the right hepatic vein and the right portal vein. So this was another companion case of a intrahepatic portosystemic shunt type 3A. Next, this is an interesting case. Here we can see this is a stomach, this is a spleen, this is a splenic vein, joining with the superior mesenteric.
No.
Sorry for the glitch. This is a stomach. This is stomach. This is spleen. This is splenic vein joining with the superior mesenteric vein forming a main portal vein. This is IVC. This is aorta, and a connecting vessel was seen between the main branch of the portal vein to the IVC. And here you can see this is a umbilical vein continuing as a portal vein sinus. The hockey stick appearance going away from the stomach, and the aliasing structure what we see here is a normal ductus venosus. You can appreciate here aliasing that was a shunt between the main portal vein to the IVC. In this case, shunt was seen persistently till term with narrowing of the main portal vein. Postnatal surgical correction was done, and now baby is doing well. Another companion case. In this prone sagittal section, we can see two aliasing structure. This is umbilical vein continuing as a portal sinus, giving a normal ductus venosus going to the vestibule, and another aliasing structure was seen connecting the umbilical vein to the IVC. In this case, postnatal scan at 3 months of age showed persistent shunt with narrowing of the portal vein with no signs of hepatic failure. So, in cases of intra and extrahepatic shunts, spontaneous closure of the shunt is expected. If no spontaneous closure occurs, coiling or embolization of the shunt can be done postnatally. We have seen few cases of isolated intrahepatic shunts in healthy adults as an incidental finding. Next two cases are very interesting. We routinely do a Doppler of the portal and the other fetal veins. When we were searching for a portal vein, we saw continuous mixing of the arterial waveform in this left portal vein and also in another portal veins. Previously, we thought it was an error, so we adjusted all the parameters accordingly, but the waveforms were consistent. So we deliberately searched for the cause, and we found a communicating fistula between the hepatic artery and the portal sinus. Here, in axial section, you can appreciate this is stomach, left side, this is aorta, this is IVC, and this is a portal sinus. A communicating vessel was seen from aorta to the portal sinus. This was a hepatic artery connecting to the portal sinus. In sagittal section also, we can appreciate shunt well, a hepatic artery to the portal sinus. A follow-up scan after 2 weeks, we saw a fetal demise. So these shunts are really tricky in the sense they can land up in any miserable outcomes. Next, also in this case, we can see in sagittal section, the blue one is actually aorta and the red one is umbilical artery giving the ductus venosus. When we were sampling the ductus venosus, we saw continuous mixing of the arterial waveform with the ductus venosus. Again, we suspected it was an error, but we adjusted all the parameters accordingly. But still, the mixing was there, suggesting a fistula extending from the ductus venosus to the hepatic artery. First diagnosed at the 15-week scan, it was large in size. Follow-up scans at 20 and 28 weeks showed persistent fistula with reduction in size. In embryology, in embryonic stage, embryo has two umbilical veins and the two umbilical arteries. The right umbilical vein regresses and the left umbilical vein persists. In normal fetus, we should see the gallbladder and the stomach on the either side of the umbilical vein. But here we can see umbilical vein portal sinus, the confluence is, instead of going away from the stomach, it is going towards the stomach. And both the gallbladder and the stomach were seen on the same side of the umbilical vein. So this was actually umbilical vein abnormally connecting to the right portal vein instead of the left portal vein, which then turns toward the stomach. The fetal gallbladder is located medial to the umbilical vein, that is between the umbilical vein and the stomach. This is a nice 3D scene of the same patient. Total 4 cases were diagnosed. All had good prognosis. There are 2 variants of the same. Type 1 is intrahepatic, has a most better prognosis. Type 2 is extrahepatic, is a rare but has a worse prognosis. These are the 2 case studies. You can go through this. In this baby, we saw a cyst-like structure in the abdomen. We were not sure what it was, either intra-abdominal cyst, pelvic cyst, or any gonadal cyst. So we put a color Doppler and the picture was clear. We saw a venous flow within it. So that was a case of umbilical vein varix. The term umbilical vein varix is defined when the caliber is greater than the 9 mm or with a ratio of more than 50% between the dilated and the more distal, narrow and intra-abdominal portion of the vein. So few key points. The presence of the intrahepatic portal venous system is key to the live birth regardless of the types. The documentation of the X, that is main portal vein to the portal sinus anastomosis with the same color flow, either blue or a red, is essential. Type 1 umbilical to systemic shunt had worse prognosis. These are the more prone to cardiomegaly and heart drops. Type 3A intrahepatic shunts showed highest incidence of IUGR and low birth weight. Type 2 ductus venosus to systemic and type 3B extrahepatic portal systemic shunt showed slight male predominance. This is a summary of the all. In type 1, there is a 100% absence of the ductus venosus. And intrahepatic portal venous system is mostly agenesis there. And it has had a most poor prognosis. Type 2 DV to systemic shunt, there was presence of the DV. So intrahepatic portal systems were present, but these types are more prone to aneuploidies, and these can have a good live birth prognosis. Type 3 and type 3B have graded or fairly good prognosis depending on the presence of the intrahepatic portal system. Type 3 had graded prognosis because those were the patient which needed the postnatal surgical closure. Conclusion: diagnosis of various types of the umbilical portal venous system anomalies can be made with detailed evaluation of the fetal umbilical portal venous system anatomy. Various outcomes depend upon the size, types of the shunt, and associated congenital anomalies. Significant number of cases were associated with the other anomalies and fetal growth restriction in the last trimester. Most these cases with isolated shunt showed favorable prognosis. Few studies have showed genetic abnormalities associated with these shunts, so genetic evaluation in these cases is advisable. Most common is a trisomy 21, other are trisomy 18, 13, Noonan syndrome. So when the vessels take a wrong turn, always look for the X. These are the nice 3D scenes of the same. I thank the Ultrasound Academy for giving me this chance. Thank you. These are my references.